So good evening, everyone. I'm Maria Kroll. I'm a member of the program committee, and I believe that Dr. Andre Abadi, who is also a program committee member, is here with us. And tonight we are hosting our Doc Talk speaker series, and I have the pleasure of introducing to you Dr. Remnem Tagore, who will be speaking to us about contraceptive counseling reimagined, moving toward reproductive justice in clinical practice. I'd like to tell you a little bit about her. Simran Tagore has a DNP and MSN and is a family nurse practitioner. She is a board certified nurse practitioner with nearly 2 decades of clinical experience in women's health, obstetrics and gynecology, and reproductive care. She practices at Kaiser Permanente, San Leandro in the Department of Obstetrics and Gynecology, and serves as a nurse practitioner quality liaison for 2 Northern California service areas, where she supports nurse practitioner leadership, quality improvement initiatives, and professional development across diverse clinical settings. Dr. Tagore's work is grounded in reproductive justice, health equity, and the belief that high-quality care must center patients' lived experiences, autonomy, and voices. She earned her Doctor of Nursing Practice from San Jose State University, where her doctoral program examined the use of reproductive justice framework in contraceptive counseling for Black African American women, focusing on patient satisfaction and providing knowledge. Her work has been presented at regional and national conferences and reflects her commitment to advancing care that is both clinically excellent and equity driven. Prior to her current role, Dr. Tagore practiced in safety net and academic medical settings, including Planned Parenthood, UCF, UCSF Medical Center, and county specialty clinics. She's a guest lecturer at UCF School of Nursing and Rutgers University, and a contributing author to clinical guidelines for advanced practice nursing. As a speaker and clinician, Dr. Tagore is dedicated to advancing reproductive health care that is justice centered, culturally responsive, and reflective of the communities we serve, while also supporting the growth and leadership of nurse practitioners within healthcare system. Welcome. And I'm going to share your presentation.
Awesome. Thank you so much. Thank you for that welcome and introduction. I'm so honored to be here talking with you all tonight. All right, here we go.
I just wanted, before we start, there will be a Q&A at the end, so you can save your questions for that. So thank you.
Thank you. We can move to the next slide. So, like I said, I'm honored to be here tonight. And before I begin, I would like to start my talk off with a land acknowledgement. The land that I am on here in Oakland, California, is the ancestral land of the Ohlone people, who are the original inhabitants of the Oakland area. Indigenous communities have lived in and moved through this land over hundreds of generations and over hundreds of years, and we recognize, honor, and pay our respects to their ancestors, descendants, elders, and all other members of their communities. And we recognize the descendants of Indigenous tribes move through this land today. In addition to offering a land acknowledgement, some communities participate in voluntary land taxes, which are self-directed financial contributions to Indigenous-led organizations and support land rematriation, cultural restoration, and sovereignty. And while this is not a government tax, it is a voluntary tax. This voluntary action moves beyond acknowledgement toward material accountability, recognizing land dispossession as an ongoing structural injustice that affects community health. Thank you. All right, next I'll move briefly to review my disclosures. Next slide. I have no conflicts of interest related to this presentation. The perspectives that I share are based on my clinical practice and research. And these are my objectives. We can move to the next slide. We're going to describe the impact of social structural racism, implicit bias, and institutional discrimination on contraceptive counseling and reproductive health outcomes in marginalized communities, define the core principles of the Reproductive Justice Framework, utilize tools and case-based examples to integrate the Reproductive Justice Framework into everyday practice, recognize how traditional contraceptive counseling may unintentionally perpetuate inequity and undermine patient autonomy, and apply culturally responsive and linguistically inclusive strategies in contraceptive counseling encounters to better meet the needs of diverse patient populations. Next slide. So I just want to make a note on inclusive language. Throughout this presentation, I use the term women because much of the research and literature is framed that way. I want to acknowledge that reproductive justice applies to all people who can become pregnant, including transgender men, non-binary individuals, and people assigned female at birth. Next slide. So to set the stage for this presentation, we need to understand the importance of contraception, contraceptive counseling, and why this topic is of importance. We're going to start by reviewing some data that informs us of how important contraception is for our patients. So it's a key component of health for many people. Individuals use contraception for a variety of reasons and not just pregnancy prevention. Nearly 40% of women say they have seen or heard something on social media about contraception, and I believe we can all probably relate to that. 82% of women say they used a form of contraception in the last 12 months, and about 78% of women receive their contraceptive care at a quote unquote doctor's office. And nearly 70% of women of reproductive age say it's very important for them to avoid becoming pregnant in the next month. And nearly 25% of women are not using their preferred method of contraception. So we can see that contraceptive care is a very essential part of overall health for many patients, and it's used for a variety of reasons, not just pregnancy prevention. Providing contraception and contraceptive care is a key element of holistic patient-centered care. So if it's the significant part of health, of a patient's health, then contraceptive counseling and access are integrals to supporting the health, autonomy, and well-being of our patients. And this is something I want us to really center as I move through the presentation. Now, I want to focus on the last data point here is why aren't women using the method they actually want? This is what I want us to start thinking about and what could be in the way or what are the obstacles of women not using their preferred method. Next slide. Next slide. Yeah, thank you. So we know that contraception and counseling is critical to our patients. Now, I just want to review some key concepts of health justice because these concepts are very central to the reproductive justice framework. I'm going to start calling the Reproductive Justice Framework RJF. It's just a much easier acronym for me to use when speaking. So health disparities, what are they? So the CDC defines health disparities as preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. So we're referring to the differences in health and healthcare between groups that stem from broader inequities. And these differences are closely linked with social, economic, and or environmental disadvantages. Next slide. So if we're going to take it even a step further, what is the root of health disparities and inequities? Well, it's a wide range of factors, both within and outside of the healthcare system, and they contribute to disparities in health and healthcare, and these are social determinants of health, defined by the World Health Organization as the conditions in which people are born, grow, live, work, and age. And these conditions are significant drivers of disease risk and susceptibility within clinical care and public health systems. Next slide. So it's important to recognize and understand that social determinants of health are a driving force behind health disparities and health inequity. It's complex, it's multifactorial, and it's deeply rooted in systemic and institutional racism and discrimination. You can see from this diagram that all these social determinants of health, safety, food security, education, economic factors, access to healthcare are all affected by racism and discrimination. This all then comes together to affect health and well-being. And the other point I want you to take away from this diagram and from previous slides and start thinking about is how all of these factors affect women of color, how we move through the world, and how they have a significant impact on reproductive health, health, well-being, and how we move through the healthcare system. Next slide. So many of us may be well aware of health disparities that exist, but I want to remind everyone of a few key health disparities. So large racial disparities in maternal and infant health outcomes persist. Pregnancy-related mortality rates among American Indian and Alaska Native and Black women are over 3 times higher than the rate for white women. And we heard about this in around 2020 and 2021. That's when it kind of made the big news. And these disparities have persisted. These disparities reflect broader underlying social and economic inequalities that are rooted in racism and discrimination. And these can include access to health insurance, type of health insurance, income, and education. We also see that teen birth rates have decreased over time, but not in all communities. The rates of teen birth rates are higher among Black, Hispanic, American Indian and Alaska Native, and Native Hawaiian Pacific Islander teens. And it's also very important to understand how teen pregnancy can disrupt education completion for the teen parent and have a significant economic and social impact as well. And what is our role in this? That's something I want us to start thinking about. Infants born to American Indian and Alaska Native, Asian American and Pacific Island, and Black pregnant women. Sorry, infants, let me read the number 4 first. Sorry. Infants born to American Indian, Alaska Native, Native Hawaiian, Pacific Island, Black and Hispanic women are at a higher risk for mortality compared to those born to white women. And while we do see an overall decrease in infant mortality rates, overall, when we look at all the statistics, we are still seeing the disparities persist, especially between Black and white infants. Now, American Indian and Alaska Native and Asian American Pacific Island and Black pregnant women report symptoms of perinatal depression more than white pregnant women. And women of color face barriers to mental health treatment that include racism, trauma, and cultural barriers. So it's clear when we look at the maternal health of Black and brown women in this country, there are clear health disparities that have persisted over time when we compare these outcomes to white women. Next slide. So the question I had, and to further develop our understanding and advocate for the need for a different framework for contraceptive counseling, we need to dive a little deeper into the data. And so the question then became, do these health disparities exist and affect health outcomes before the perinatal period in the lives of Black women? Next slide. And the answer from looking at the data was yes, absolutely. Black and Latina women have higher rates of unintended pregnancy than white women. The National Survey of Family Growth from 2006 to 2010 showed that Black women use effective contraceptive methods less often when compared to white women. And Black women who were more likely to experience an unintended pregnancy were at risk for non-contraceptive use. Next slide. So keep in mind what we saw a few slides ago about health disparities and social determinants of health. These are factors we want to consider in these disparities. So let's discuss this. So in the context of contraception, distrust in the healthcare system can be greater given the history of forced sterilizations of Black women and coercion by some family planning programs. We cannot forget the history of forced sterilizations in this country of Black women in the South, Native American women, and in Puerto Rico. This history is fresh. It's less than one generation ago. And most recently, there have been reports from nurses in Georgia reporting forced sterilizations of women held in ICE detention centers in 2020. And we can only imagine what's been happening since then. A study in 2020 found that providers had a greater inclination to promote IUDs to Black and African American women, regardless of socioeconomic status. This is deeply problematic and is not that long ago either. 2020 was just 6 years ago. There are concerns about reproductive autonomy being hindered by providers' own biases and beliefs. This finding came out of a study to examine the experiences of minority women in postpartum counseling. And it's important to understand that if you feel like your autonomy is being threatened, there's no trust. And if there's no trust, you can't really provide true, authentic care. Next slide. All right, so we reviewed some concepts of health justice. We look at social determinants of health, and we examine data. So I want to talk about what's at the center of this presentation as well, which is contraceptive counseling. Contraceptive counseling is based on a few key principles. This is the foundation. It's based on the concept that basic reproductive and sexual health rests on the idea that all people should have agency over their own sexual and reproductive lives. So if we believe that all people have this agency and this is an expression of their humanity, then this isn't a medical issue. It's a human issue, and that's how we should approach it. Contraceptive counseling must be approached with care, awareness, and with a health justice lens. And it's important to remember that the context in which you provide contraceptive counseling is really important, and to have a health justice lens. Contraception is a human right and is considered primary health care. Next slide. So now we have a foundation of what contraceptive counseling is and a definition that can frame contraceptive counseling. Let's talk about how we do this and what methods are used in counseling, why they lack a health justice lens, and what we can do to change that. Next slide. So these are the four main counseling methods that are used in counseling in general that have now been applied to contraceptive counseling as well. Directive counseling methods are most of the time characterized by implicit bias because the provider is the one directing the conversation by what they think is the best method for the patient. Tier-based methods of counseling can be patient-centered, but it focuses on the most effective method and not on what the patient may want in their own autonomy. Informed choice counseling methods are non-directive, and they do position the patient to make their own decision, but there's no recognition of the effects of racism and discrimination on the patient's life. Shared decision-making is actually the preferred method by the larger and leading reproductive health organizations, and it allows the patient to be involved in the counseling session with the patient's choice of contraception driving the conversation. But a key thing that's missing in this particular way of counseling is it doesn't make any mention of a health justice lens. Next slide. So currently, the American College of Obstetrics and Gynecologists recommend the use of shared decision-making. It is an ethical approach. It's based on patient-centered counseling. The patient is actively involved in the decision-making. Patient choice is the priority, and the provider does not communicate their preference, nor should they be motivated by their own values. It's all about the patient. So while this is the best method and it's recommended, again, there's no recognition of the effects of racism, discrimination, and social determinants of health on the patient's views, choices, and overall well-being. Next slide. So with shared decision-making, there's plenty of data to support that patients who receive contraceptive counseling using this method that is centered on principles of shared decision making report better experiences. And we do see an increase in the use of contraception when patients are counseled using shared decision making. But it's pretty complex. There's no agreed upon definition of it, and gaps still remain. So studies have shown that even with the use of shared decision making, provider biases exist for or against certain methods, and patients opt not to use any method. Data also shows that while shared decision making increases uptake of contraception for some patients, it is still tainted by bias and discrimination. So even when using what we think is the most effective and most patient-centered method of counseling, there still is a perception and experience of provider discrimination and bias. So it's a great method of counseling, but there's still so many concerns and gaps. Next slide. So I want us to think about what patients experience and what is their perspective and what trends are we seeing in data that talk about patient perspective in contraceptive counseling. Studies have shown that patients value autonomy when making decisions. They want to feel like they have a choice, that they have a say, and that it's their right to decide. At the end of the day, patients are perceiving bias and discrimination, and this is deeply problematic. Even with the well-intended counseling methods such as shared decision making, there are still perceptions of bias, coercion, and women of color are still experiencing racism and discrimination. Next slide. So now let's look at how healthcare workers experience. What is their perspective in contraceptive counseling? So there was a systematic review of literature done, which reviewed 41 articles across 27 countries, and it included over 12,000 healthcare workers. And it was discovered that healthcare workers hold their own beliefs and biases, and this directly impacts care. Specifically, it showed that healthcare workers hold beliefs about the contraception that should be given to adolescents or women who are not married compared to older or mature women. Demographic information such as patient age, level of literacy, marital status, and history of pregnancy all influence the healthcare worker's beliefs on which contraceptive methods should be given to the patient. So we can see that it's not just a perception from patients that of this bias, it's actually real and it does actually exist. Next slide. So how can we do better? That's the question I know I personally was left with at the end of the day. We have recommendations from leading reproductive organizations that urge clinicians to use shared decision making, a counseling method that is ethical and based in patient-centered counseling, but it doesn't address or account for the bias and discrimination that patients are experiencing and seeing, or the health disparities that we see. So ACOG, one of the leading healthcare organizations, actually came out and made additional recommendations. They advocated for the use of the Reproductive Justice Framework. And that's how we do better. Now, the thing that stood out to me when ACOG came out with this recommendation was they simply came out with a statement, right? They said, we recommend using shared decision making, but also use reproductive justice framework, but they didn't give any guidance, they didn't give any resources, they didn't give information on what that framework is. Next slide. So contraceptive counseling must be provided through a racial and health justice lens. We know that, we see that, and communities with a history of reproductive and medical coercion must be considered in this counseling and in this movement. And the RJF provides an excellent framework on how to do this within reproductive care. Next slide. So the Reproductive Justice Framework was developed in Chicago in 1994 by the Black women founders of the Women of African Descent for Reproductive Justice. These women were a part of a group that would go on to form Sister Song, Women of Color Reproductive Justice Collective. This has since become the organization Sister Song. It's the main organization based in Atlanta that is pioneering the reproductive justice cause. It's a great resource. It's the organization I use for my doctoral research, and they're incredibly accessible. So why did they come together to form this framework and form this organization? Well, the reproductive rights movement at the time was predominantly focused on the priorities of white middle class women. And that focus was on legal access to contraception and abortion. It was an individual choice, right? Um, Now, this is important, but it's also important to know that that choice or individual choice isn't the same or equal for every woman. Black, Indigenous, and other women of color face broader systemic issues. This included immigrant women, low income, and disabled women. They face systemic issues such as discrimination, poverty, environmental injustice, criminalization, and a history of coercive population control tactics, such as forced sterilizations. So it's difficult to frame the idea of choice when many women have very different access. So choice is meaningless without access. And we're talking about access to safe housing, affordable healthcare, healthy food, and the right to raise children in safe environments. Next slide. So the Reproductive Justice Framework, or RJF, is a way of framing reproductive choice and care. It's a framework that is rooted in human rights and social justice, and it's an acknowledgement that reproductive oppression is tied to race, class, gender, sexuality, ability, and immigration status. Next slide. So let's define the key concepts of the RJF and its core principles. At the heart of the RJF are three key principles or human rights that broaden the way we think about reproductive health. It's important to remember that reproductive justice moves us beyond the idea of individual choice and instead asks whether people have the freedom, they actually have the freedom to access and support and to live out choices they want to make in their life. The first principle is the right to not have a child. So this is access to contraception and abortion that is safe, affordable, and grounded in informed consent. It's about having true autonomy over one's own body and reproductive life. The second principle is the right to have a child or have children, to decide if, when, and how to grow one's family. This is free from coercion and it's free from discrimination. And for many communities of color, this hasn't always been a given. Historical injustices like forced sterilization or barriers to fertility care reminds us that this right has not always been equally protected. And then the right to parent children in safe and healthy environments. Um, Reproductive justice just doesn't end with pregnancy. It includes the right to raise children without fear of violence, poverty, environmental harm, and with access to healthcare, housing, and education. It recognizes that the reproductive health of Black women in this country has been impacted by a deep-seated history of racism, medical coercion, and mistrust. And these concepts can also be used to care for patients from communities of color and other marginalized communities. Next slide. Now, I just briefly want to talk about RJF in the literature and the limitations of research on the RJF. Research on the use of RJF and the outcomes of its implementation is very limited. The concepts of RJF are relatively new and have not been widely adopted. A 2023 study in North Carolina reviewed how state-funded programs were able to improve community contraceptive counseling within their community by recognizing that counseling for long-acting reversible contraception was perceived as coercion by their community. They adopted the RJF, they trained their staff and their clinicians, they used Sister Song in their organization and for their trainings. And they found that while there were limitations to the study, they didn't evaluate for patient satisfaction, but the staff themselves expressed improvement in how to center patients' experiences in contraceptive counseling. Next slide. So while we don't have much research on the RJF, we do have research on what isn't working, right? Another study done in 2017 in Chicago focused on the experiences of African American women in contraceptive counseling. And they found that from their focus groups that there were three main themes about what women wanted in their contraceptive counseling visits. They wanted autonomy and equity, they wanted respect, and they wanted trust and open communication. We also know that women of color, immigrant women, and women from low income communities face barriers when seeking reproductive care, and this impacts access. And it's up to us to recognize this and make a difference. Next slide. So when you're using the RJF, you have to be aware of a few key ideas and concepts and put in the work to provide your patient the care they deserve and need. The goals of using this framework and these concepts in contraceptive counseling are to allow the clinician to recognize their own implicit bias. And this may be something that you have to address and work on, and it's difficult. Clinicians should be focusing contraceptive counseling on the patient's desires for bodily autonomy and consider how structural and systemic racism has impacted the lives and health of women in this country. Next slide. All righty. So using the RJF in contraceptive counseling requires us to invest in the patient's experiences and preferences, respect the patient and see them as a person, listen to their values and center their values. Using open-ended questions, being empathetic and compassionate, all the things we've learned about on how to do and how to talk to our patients. And then ask the patient what they want. If they even want contraception, they may not be in the space to even talk about it or listen to it. And then ask what they do know. Many times patients come in with ideas with with TikTok and social media. You'd be surprised what patients have heard and seen. So it's really important to ask patients these questions and to debunk myths, provide factual information to our patient. And that is really the goal. Use this as a chance to talk. Next slide. So let's talk a little bit about the skills required in the RJF and how to accomplish one. So the first one is center autonomy and informed choice. Provide comprehensive, unbiased information about all contraceptive options. And this does require you to check your biases at the door. And I know this is hard for us many times as providers or as clinicians. We come in with our own opinions, our own ideas, and often patients seek our opinion. They want to know what we think. I can't tell you how many times patients have asked, well, what do you use? What is your favorite method? And this is hard because we can't just sit there and talk about ourselves. It's not about us, it's about the patient. We have influence. You can't just memorize efficacy and the method of action. You really want to focus on the patient. And if this is difficult, you have to work on this. Secondly, you want to include the choice to decline or discontinue a method. And I think this is also really hard and challenging for some providers because they take it personally, as if their patient's desire to not use contraception is a reflection on their practice, but it has nothing to do with us. This is all about the patient and their autonomy and desire to use or not use a method. Patient has a right to have their IUD removed, to have their Nexplanon removed, to stop the pill without any reason. And as a collective, I think we should stop trying to persuade patients to keep methods. And some people are shocked to hear this happens, and some people are not. And it's because this happens quite regularly. Next slide. So you also want to recognize historical context, acknowledge the legacy of coercive practices, recognize how these have eroded trust, and understand how this may show up in your patient interaction. As I said before, these include forced sterilization, ways in which women of color have been pressured to use long-acting reversible contraception. Be curious. When I have patients tell me something or say something about an experience what they had, I acknowledge it, I affirm it, I ask them what happened if they want to talk about it. These women have often not had their experiences affirmed, and it's critical to do that to build trust. And then you want to address structural barriers. You want to consider access issues. Look outside the box. Think about transportation, language, appointment availability, things that may not be as obvious. Next slide. Um, Again, we're going to practice shared decision making. Remember that this is still the core of how you counsel. You're just going to use a reproductive justice lens and use the RJF. So questions like, what feels right for you in your life right now? So we're moving from what's best for you is to asking the question, what feels right for you in your life right now? Keep in mind that this is the patient's choice. Autonomy is at the center of this counseling visit. And you want to validate lived experience. Listen for social, cultural, and personal factors. These all influence patients' contraceptive choices and perspectives. Patients have the right to define their own reproductive goals, and we have to support that. And remember and understand how their experiences, history, and legacy all show up in their visit and how they experience healthcare in their reproductive lives. Next slide. So I want to point out that contraceptive guidance, the goal is not to have every patient leave with contraception, but rather to remove the barriers to access to contraception and provide evidence-based information. And again, I think this is one of the more challenging parts of this method, of this framework. Because our clinician minds may not be aligned with our patient goals, but it's not our goal, it's our patient's goals, and they're at the center of this visit. And this is where you can use a reproductive justice framework to recenter the visit and recenter yourself. Next slide. So we can do all the work as clinicians to understand the RJF conceptually and even use it in practice, but the challenge lies in how we adopt it and make it a fabric of the care we provide. We need practical clinic level tools to put into action. So I wanted to share some more concrete evidence-informed tools and strategies that you can use, adapt, and share. And I know we all may work in different settings, but just kind of take from it what you will or be inspired from it. So we want to integrate, embed, and sustain the RJF. So integrate RJF into daily workflows and clinical decision makings, embed RJF principles into conversations and relationships, and sustain RJF through structure. And I think this is the most comprehensive and adaptable way so that this feels actionable and it doesn't feel abstract. Next slide. Okay, so integrate. How do we integrate the RJF into daily workflows and clinical decision making? So when counseling, use shared decision-making tools and continue to use shared decision-making methods. So bedsider.org is a great option that talks about all the methods. It's a website. I believe it may be an app as well. I often refer it to my patients because it has a lot of resources. It breaks down methods in ways that are helpful and meaningful, and it has a method explorer that can compare different methods for the patient. Person-centered contraceptive counseling framework is a framework out of UCSF and their person-centered reproductive health program. It was designed in 2020 to guide clinicians, to researchers to consider a broad range of factors that influence equitable access to high quality person-centered contraceptive care. They have a decision tool for contraception that is also a really good resource. Next slide. Oh, and I'm sorry, you can go back. I forgot the last point. But I think the last thing I wanted to say about that is it's our goal is to find out what method works best for the patient right now. You can stop the method at any time. And so I think that's really important to say to the patient as well. Next slide. All right, so the other thing we want to do for integrate is we want to see if we can put charting and templates and integrate RJF into our electronic health records. So you can create templates that prompt RJF use. You can create an RJF checklist. You can create handouts to give to patients. We want to always use trauma-informed practices. Ask the patient before touching, pause and listen, and use appropriate body language. And I recognize that we all work in different systems, and maybe integrating into EHR is not as easy as it sounds, but I think that you can always have a mental checklist for yourself or a smart phrase even about the RJF. Next slide. And then we want to embed the RJF into conversations and relationships. I believe that this is one of the most crucial aspects of ensuring that the RJF is accessible and being used. I find that people don't know what this is, they haven't heard of it, and there's a big gap between definition and application. In my clinic, we got a lecture on the RJF probably about 5 or 6 years ago. Nothing, no tools, no ideas on how to integrate, no even concepts really about it. So to me, this is critical work, and this is where the critical work lies. So one thing you could do is create a group or a peer group that focuses on the RJF. Have conversations around bias, review recent data and literature around RJF, and use it as purposeful reflection. These can be groups that meet periodically. It can be personal reflection, like I said. But questions such as, which methods do I tend to recommend most and why? And do I unintentionally frame some methods as better for certain patients? And how might my assumptions about family and lifestyle show up and reflect my bias? And then you want to educate and empower. You want to provide education to our MAs, our nurses, all the stuff that's involved, because all these people will touch our patients in some way. It's not just us in a vacuum. And then you want to give the talk, educate your patients, give the lecture if this is something you're inspired to do. Next slide. So also embedding the language. So embedding the use of RJF into language, clinical conversations, remembering to reframe your value. Sorry, remember to reframe your language, values clarification, and autonomy reminders. Next slide. So sustain. So I know for me, I'm part of a larger organization, and at times I'm not positioned to provide input in some decisions that are made for my practice. And so the issue then becomes, how do I sustain the RJF in a structure that I'm not necessarily privy to making these decisions for? And sometimes it's not easy, the answer isn't clear, but that's why we have to be persistent and we have to hold our values in our practice. So normalize talking about equity and bias. Talking about equity and bias should be integrated into everyday language. It should be discussed and talked about as often as safety and quality. It can be discussion in huddles. When we talk about cases or we talk about our day or we're doing check-ins, we should talk about, did we see anybody who's affected, whose access affected their care? Did we see anyone where systemic barriers affected care? We can all learn so much more when we talk about it in this way, in a meaningful way to make meaningful change. Keep resources and keep them handy. A list of community resources for patients, for colleagues. This could be a local resource list, a list of reproductive justice organizations, social work. Make access and resources a part of your clinical tools. Like I said, discussion in huddles and check-ins, and integrate RJF and its use into patient care experience and quality. Patients should be asked about their experience as it relates to RJF and autonomy. This should be a part of focus groups. I will say that there's no patient satisfaction survey that focuses on the RJF. I know this because when I was doing my doctoral research, I had to create one. It's not validated as a survey because I just created it on my own. But if anyone wants to see it or has any questions about the questions I ask patients on this survey, please let me know. Because their input matters, and just because it doesn't exist doesn't mean we can't make it. Next slide. Okay, so I am going to go through this case study with you. I'll just kind of tell us the answers as we go through it so people don't have to go off mute and we don't have to take a poll or anything like that. I'm going to discuss these. I just want you to get an idea of how RJF can show up in practice, right? So this is a 26-year-old patient assigned female at birth, sexually active with a male partner. They have had an Mirena IUD for 3 months and now they want it removed. In reviewing their chart, you notice that she previously had an Explanon right before this IUD and also had that removed after 3 to 4 months. Next slide. So what comes up for you as clinicians, as people in healthcare, as human beings, whatever ways you move through this world, there are going to be things that come up. Do you want to ask why she wants it removed? Do you feel a sense of frustration or judgment that she shouldn't have it removed because she just had the next one on and it's only been 3 months? And for some of us, we know that the IUD can have side effects that last for 3 months, 6 months, 8 months. Do you want to persuade her to keep the IUD? And I think all these reflections are normal. And we have sometimes been conditioned and taught to think of contraception as a privilege and something that should be done and should be kept. And you're so lucky to have it. But by thinking this way, we remove the concept of autonomy and that our patients have the right to do with what they want with their own bodies. And this includes not using contraception and using whatever method they want. Next slide. So the RJF informed approach to this would be to honor the request first. Removal does not require justification. You can invite discussion rather than require an explanation of why they want it moved and support the patient's next contraceptive choice. I think we always want to ask why, and I do believe that the question of why comes from a good place. Providers want to understand side effects or see if there's a way to address the problem. But from a reproductive justice framework, the important shift is recognizing that patients do not need to justify their decision to discontinue a method. The device is in their body, and autonomy over that decision belongs to them. So invite conversation. If they want to share what's going on, great. If you'd like to share what's going on with the method, I'm happy to talk about it. No, I don't want to talk about it. Fantastic. Move on. Discussion is optional and patient-led. It's not a prerequisite for removal. Next slide. And this is just kind of more of what I went over, that clinicians sometimes can feel frustrated or confused, wondering if the patient's non-compliant or impulsive. Sometimes clinicians feel like they're not doing a good job. And this can come up as subtle judgment, and it may also reflect messaging about ideal contraceptive use. Curiosity can be helpful, but it has to be grounded in respect, not in interrogation. And again, patient autonomy and self-determination are important and they are measures of quality care. Next slide. All right, so the next scenario is an 18-year-old patient for gynecological symptoms. That's why she has come in. You're asking about sexual activity, and then you ask about pregnancy planning. And she shares that she's finishing high school and that she and her boyfriend are ready to have a baby. Next slide. So here are some responses, and we're going to pick which one reflects the reproductive justice framework. A, telling her she's too young to have a baby and discuss starting birth control. B, tell her that pregnancy at her age is a mistake and that she should finish college first. Or C, acknowledge her readiness and congratulate her on thinking ahead, explore her goals for pregnancy, and discuss preconception wellness to help her prepare for a healthy pregnancy whenever she decides it's right for her. Next slide. So options A and B, no matter what you feel about it, it's biased. They are not rooted in the RJF. If you're truly practicing using the RJF, you want to prepare this patient to have the healthiest pregnancy she can because it's her right to have a baby when she wants and raise it in a safe and healthy environment. That is one of the key components of the reproductive justice framework. So this response, C, validates the patient's autonomy, acknowledges her reproductive goals, and provides support in non-judgmental education. Next slide. So the Reproductive Justice Framework asks the following of us: to acknowledge context and history, recognize reproductive coercion, racism, and systemic inequities that shape patient trust, practice with humility and awareness of historical harm, and acknowledge that trust must be rebuilt through transparency and respect. You want to promote access and equity, address barriers like insurance, transportation, privacy, and language. Use interpreters when needed, flexible scheduling, and cost discussion as a part of care. Ensure culturally responsive and linguistically inclusive care. You want to practice shared decision-making, present full contraceptive options and validate patient goals, use patient-centered communication, support patient-led decision-making, support patients' reproductive goals on their terms. And you want to reflect and reassess. Examine your own assumptions and biases around contraceptive and family planning. Ask whose needs are being centered. Is it mine, the system's, or is it the patient's? Practice curiosity over correction. Listen for what matters most to each patient. And I want to add that it's also really important to advocate beyond the exam room. Map and share local reproductive health resources, which is Title 10, Abortion Funds, Reproductive Health Access Project. Include RJF principles in quality improvement, onboarding, and leadership discussions, and use your influence to remove barriers to care within your system. Next slide. So I share all of this with you with so much gratitude. Reproductive Justice Framework and Contraceptive Counseling has been a passion project of mine. I was lucky enough to do my doctoral work on it. The Reproductive Justice Framework reminds us that healthcare is not neutral. It is shaped by history, power, and access. Each patient encounter is an opportunity to affirm autonomy, rebuild that trust, and reimagine what equitable care can look like. I thank you so much for engaging in this conversation, to DNPs of color for having me, and for your commitment to advancing reproductive justice in your daily practice. Next slide. I just wanted to throw this in there. This is the Reproductive Health Hotline, or ReproHH. It is put on by the University of California in San Francisco. Experts in sexual and reproductive health available to answer on demand your questions about all these things and more. You can visit reprohh.ucsf.edu, or you can scan this QR code. It's free. It's for clinicians, by clinicians. Any US-based healthcare providers in all practice settings, such as physicians, nurses, nurse practitioners, pharmacists, midwives, they can all access this hotline. Doulas and community workers are also welcome to use it. They cannot take calls from patients or their family and friends. That's all. So I just wanted you guys to have that resource. Next slide. So please feel free to contact me with any questions, concerns, you want to talk. I'm grateful to share this work with everyone here who believe, as I do, that justice and compassion belong at the center of every clinical interaction. Together, we are shaping a future where reproductive health is truly grounded in equity, access, and respect for all. Thank you so much for this opportunity. Again, thank you for your time. Again, there's my email if you need to reach out to me. And the next slides are my resources. Great.
Thank you so much. Now, if anybody has any questions, this is your time to. I,
I think you may want to mute yourself.
Are you asking a question or? So there's some comments.
Okay.
Ina, somebody raise their hand or no? Ina, Andrea Arce, yes, let's normalize talking about equity and bias.
Yep.
Michael
Yep.
Williams, thank you. This was an amazing presentation and much needed topic for us to always find ways to improve practice.
Yep.
And such rich and practical information. Thanks for such an amazing presentation. Any questions, comments? All right, I'm going to thank you for information and empowerment.
Yep.
And then Ina wants.
There is one question.
Yeah.
What's
where
Ina
Andrea.
asked, what's been your experience with organizational policy change?
Yeah, so my organization is Kaiser, and there's no policy per se on how to provide contraceptive counseling. There's more just, I think, the ways in which people do it. I have offered to give this same presentation to the physician colleagues I work with, which has been met with, okay, yeah, just let us know, and has not been scheduled. But I have provided this presentation for all Northern California NPs at a regional level. So the information is out there. I think in all honesty, I think it's up to the providers to demand change, to enforce change, to practice this way, and for other people to realize that the way we are doing things, the old way of doing things is not working and that there needs to be changes. So I think, think globally, act locally. That's how I've kind of approached it. And I also take feedback from my patients. Most of my patients I see come out of the visit and they say, no one's ever spoken to me like that. No one's ever just, let me decide. And I tell them, take these things you've learned and move forward in all your visits. When you have friends or when you're talking about it with your girlfriends, please give them this information about reproductive justice and encourage them to be advocates for themselves. And so I think that's also the important way is patients demanding the type of care they deserve.
Alicia has her hand up. Alicia.
Hi, Alicia. Yes. Hi. I have a question about how does the framework address once harm has been done? Something has happened.
Yeah.
A client has a complaint. How does the framework suggest you repair once harm has been done?
Yeah, that's a good question. Repair takes time and healing takes time. So the way I've approached it is that it's often just come up in a visit with a patient where, for example, what really sparked this for me was I was seeing a patient to have their Nexplanon removed, and she sat there and she's like, I'm like, oh, okay, you're here to have your Nexplanon removed. She's like, yeah. And I said, great. And I just started telling her about how I was going to do the procedure and how it would go. And she started crying just right there. And I was like, oh my God, is she scared? What did I do? So I just sat with her and I said, it looks like this is causing you to have a little bit of a response. Do you want to share what you're feeling? Um, and she did. And what she told me was that she had been trying to get the Nexplanon removed for about 3 or 4 months. Every provider she had gone to, 3 or 4 different providers would not remove it. And so when she saw me and I was like, let's just take this out, she was so relieved and overwhelmed that it could go this way. And so we had a conversation about her experience, about how to advocate for herself moving forward, about what she needs. And I just offered myself as a provider to her if she had any questions in the future. Unfortunately, our healthcare system is not created to allow for these type of visits, but when it happens, you just make the adjustment in real time.
All right, thank you. I'm going to continue sharing my screen because we have a survey to fill out. So upcoming events for members only town hall, September 15 at 8:30 p.m. Save the Date 2026 Annual Conference, October 15th through October 18th in Detroit, Michigan. Follow us on DNPs of Color, DNPs of hashtag DNPs of Color and hashtag DNPs. And our website is www.dnpsofcolor.org. And here is the QR code. And this is a QR code for the presentation tonight. So if you could take time to fill out the survey, we would really appreciate it. I want to, I don't want to stop sharing my screen, but I wanted to say thank you so much, Dr. Tagore, for this great presentation. And thank you, everybody, for joining us tonight to listen to it.
Thank you so much for having me. Have a good night, everyone.
Good night. Thank you.
Thank you.
Oh, I'm going to, hopefully everybody had an opportunity to take a screenshot and thank you, everybody. Have a good night.